Hello, everyone, and welcome to today's webinar, PDPM, PDGM, How OT Can Demonstrate Value in Changing Times. My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn one CE contact hour for each webinar attended during Member Appreciation Week. At the conclusion of the webinar, you will receive an email from AOT Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate email. You will have through December 31st to obtain your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question box. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered towards the end of the webinar, and the presenters will do their best to answer as many questions as time allows. And last, resources. The PowerPoint presentation for this webinar is available for download and can be found in the Event Resources box located just below the Ask a Question box. Simply click on the pull-down arrow to view the document and download. And with that information, let me introduce today's presenters, Jeremy Furniss and Sharmila Sandhu.
Thanks so much, Amanda. All right, let's jump into Volume to Value, PDPM, and PDGM, how OT can demonstrate value in changing times. So our learning objectives are listed here and are also a part of the general description. We've got a lot of content to go through today, so we're just going to jump in to the transition from volume to value. So across healthcare settings and even other health settings, we're seeing a big payment shift from volume to value. The goals here are to change the incentives for organizations and systems of care to provide better quality care that achieves common outcomes that are of interest to health systems and also consumers of healthcare. So we're moving from fee-for-service, where we've seen things like minutes of therapy, units of therapy, and other factors like number of visits from physicians even really driving up cost. Now we're focusing on outcomes and quality measures, which looks at the value-based payment. And so we're seeing this hit really hard in post-acute care right now with PDPM and PDGM. But know that this is not exclusive just to post-acute care or home health or skilled nursing facilities, but is a larger shift that we're seeing, not only with Medicare, but with private insurance companies and other third-party payers. It does create an opportunity for OT to focus on quality and evidence-informed services rather than on the quantity. So we know in the past there have been incentives to provide more and more and more therapy, and we're hoping that in the value-based system, there's an opportunity to provide better, and better care. So under this value-based system, the incentives that are designed for the healthcare systems are to maximize staff that have an impact on the quality measures, to minimize staff that have little or no impact on quality, and to focus on collaboration and documentation that identifies value across the interdisciplinary team. And then finally, for us to be able to identify gaps in practice and gaps in outcomes, and then take that information from identifying where there are gaps and take steps to improve the care that we're providing and the outcomes that the clients are achieving. So as a part of a larger system at AOTA's Volume to Value program, we put together a group of experts from across the country and also completed a nationwide survey and worked to identify high value areas for occupational therapy. So we've identified these key areas for the analysis of occupational performance. ADLs, instrumental activities of daily living, functional cognition, vision, psychosocial and behavioral skills, fear of falling, habits, routines, and roles, or as we call them, performance patterns, and then also some type of a safety screen or an acknowledgement of safety, which really is looking at the person, the environment, and the occupation match. So these are all key areas that are obviously and very clearly related to the practice of occupational therapy, but they're also connected and related to quality measures and outcomes that are really important to the healthcare system, to payers, and to the clients that we serve. So you'll see us kind of reference back to these core areas. So I thought we'd provide a brief overview. I'm sure many people on this call are well aware of the things that are going on, but let's provide a brief overview of both the patient-driven groupings model and the patient-driven payment model. So we'll start with home health and PDGM. So big changes are happening on PDGM as of January 1st of 2020. So we'll kind of look at where we are today before January 1st, and then what's changing as of January 1st. The reimbursement in home health is really based on three broad categories right now. One is clinical dimensions. So that includes things like diagnoses and comorbidities. One is functional dimensions. So that includes how independent or dependent someone is in performing some basic ADLs and mobility items. And then the third is therapy utilization. So there's certain thresholds that once you provide more therapy, OT, PT, or speech, you get a bump in payment. And after we've talked about the difference between volume and value, it shouldn't be a big surprise, but this number 3, the therapy utilization, is the big change that we're seeing in January 1st. So what does that look like? So right now, if you provide more OT visits, or PT or speech, but we'll focus on OT, if you provide more OT visits, then you have the opportunity to increase reimbursement in home health. So once you cross one threshold, you get a bump in payment. And then once you cross another threshold, you get an additional bump in payment. And then what that looks like after January 1st is the reimbursement, the payment to the home health agency does not change no matter how many therapy visits are provided. So every single group of therapy visits still provides the exact same reimbursement for that home health facility. So if we're not using therapy visits to determine payment anymore, I thought it would be nice for us to look at what does determine payment. So CMS designed PDGM to be reimbursement based on characteristics, and there's several characteristics that they look at. The first is the admission source and timing, and that comes from the claims document. And that could be early or late, and it could also be from a community or from an institution. So from the claims, CMS looks at admission source and timing. The second item is the clinical grouping. And this comes from the principal diagnosis that's reported on the claims. So that principal ICD-10 code really determines which clinical group a person goes into. CMS determined these clinical groups using information from past claims and past home health visits. So it's basically the types of services that were provided over the last couple of years, then developed and turned into these clinical groupings. Finally, they also look at functional impairment level, and this comes from the OASIS items in the M1800 items, I believe. And so your functional impairment could be low, medium, or high. And then last but not least, there's also a comorbidity adjustment that comes from the claims documents. So if there are a certain number or severity of comorbidities, then that may adjust the reimbursement for home health as well. So I wanted to address the clinical groupings just briefly. So if you scan through these groups that someone could be assigned to, you'll see that 2 have rehab, neuro rehab and musculoskeletal rehab. Rehab is in 2 of these names, and rehab doesn't show up in any of the other names. But the reason that it shows up in these 2 is because when CMS ran the data, therapy and rehab services were the primary driver of cost for these 2 clinical categories. So that means the other clinical categories, it does not mean that rehab was not provided or OT was not provided. It just means that OT was not the most expensive thing that was provided. And so I say that because we need to acknowledge that therapy is not limited by clinical grouping. So just because 2 groups have the word rehab in them, OT should and can be provided to anyone in home health who has a skilled and medically necessary need. So these are the functional items that determine that functional level, and you can take a look. We've included the specific number of the item and the description of the item. Now, I want to point out, we've been talking a lot about Section GG over the last few months. And as of January 1st, the entire Section GG also shows up in the OASIS. And so it's a little bit tricky because CMS is adding Section GG, but they're using the old M items to determine payment. So we wanted to acknowledge that the M items and Section GG both measure function. They measure function very differently, and they are used in different ways, but both items show up in the OASIS. So what can we do to prepare for PDPM? The first thing is know your organization's quality measure scores. You can see the home health evaluation checklist, which is linked here that you can download in the PDF. And we've included many of the key measures for occupational therapy starting on page 2 of that evaluation checklist. You can ask your agency staff or even visit Home Health Compare to take a look at your facility score on these measures. And then start to ask, how is OT connected to outcomes? What is it that OT is doing now that is connected to these outcomes that are important? We also want to start really focusing in and only providing high-value services. So starting today or tomorrow as we're treating clients in the home health environment, it's really important for us to stop and look and think, is this service a high-value service? There's many, many, many high-value services that OTs provide, and so that's where we need to be focusing our efforts. And then finally, we really need to be able to advocate for our role and engage with the interdisciplinary team. It's incredibly important in any setting, but especially for home health, because it is so easy for home health to operate in silos because many of us are only seeing a client one discipline at a time, and we don't have the commonality of the hallways or common building where we run into each other and have those conversations. So it takes extra effort. We also want to point out that preparing for PDGM, there is a one-day conference that is in November in Silver Spring, Maryland. The cool thing about this is you can join in person with us in Silver Spring, but you can also sign up now and stream on demand. And if you stream on demand, you can stream that anywhere, and you can ask each speaker individual specific questions, and we do our best to answer them. So you get to participate fully and completely from the convenience of your clinic or anywhere that you have a computer. With that, I'll transition over to patient-driven payment model for skilled nursing facilities. As you all know, this went into effect on October 1st of 2019. So we are just barely a month into PDPM. And the basics of this is the MDS is completed at admission. There's 2 factors from that MDS that determine the portion for the OT payment. And those are the primary reason for skilled nursing facility admission, which comes from Section I, and the functional score, which comes from Section GG. So I want to point out that the daily rate is adjusted for OT based on the amount of OT that was provided to clients in the past few years, but facilities get to be creative in how they use that money. So providing more OT services does not increase reimbursement. Providing less OT services does not decrease reimbursement. But the crux is achieving better outcomes for clients across the facility can actually increase and influence that reimbursement. So it's really important that we're connecting our services not to the number of minutes that we're providing, but to the outcomes that we're helping our clients achieve. Now I'm going to hand it over to Sharmila Sandhu to discuss about the organization's responses to PDPM.
Thank you, Jeremy. My name is Sharmila Sandhu. I'm the Vice President of Regulatory Affairs with the American Occupational Therapy Association. So I'm going to begin by talking to you about after PDPM went live on October 1, some of what we started to hear and to see in the community and in the skilled nursing facility in the larger community. So one of the things that we wanted to note about the environment, there's a couple of different things. As you know, the model went live on October 1st, 2019. If we had actually about a week or 2 in advance of that started to hear that some facilities were responding to the reimbursement changes by taking a number of different actions. Some of the first things that we started to hear about were potential job losses, reductions to workforce, and in addition, and or some hour reductions. And so one of the things that AOTA immediately moved into doing was to collaborate with the American Physical Therapy Association and the American Speech Language Hearing Association to release a joint statement and to request that our collective members send us in their stories about how they're being impacted, how their skilled nursing facility is responding to PDPM implementation. As you might imagine, all of the emails that we've gotten hundreds and hundreds of emails, and they are anecdotal. We don't have hard data on any of these things. However, in looking at the emails and looking at the trends, there's some things that we can share in this presentation, and also some advice that we can give to practitioners in both the SNF setting and as PDGM becomes effective on January 1 of 2020, some advice for preparing for PDGM. So again, no systematic way to know exactly what will happen, and the scale of this is something we're still reviewing and understanding as we review the emails and we talk to the industry. We're just over 1 month into the implementation. So the comments that we're about to go through are based on the information we have to date and do not yet represent a sort of a full scope of what is happening out there, or probably what we know at this point. So we can share some of this information. Go back one more. So what is happening? Some occupational therapists and employers or managers in SNFs are mandating changes in clinical practice based entirely on reimbursement changes. We also know that other skilled nursing facilities have decided that they are going to continue to use best practices throughout 2019 and may make small adjustments while maintaining clinical decision-making among their therapy staff. I wanted to be clear here that AOTA recognizes and truly applauds those skilled nursing facilities that are refocusing their efforts at providing clinically appropriate and patient-centered care that allows for a therapist's clinical judgment to guide their plan of care. We also know that this meant that some skilled nursing facilities may have needed to make workforce reductions in order to refocus on best practice. At the same time, our primary concern at AOTA is with mandates to occupational therapy practitioners that do not or may not take into account the patient's clinical need, as you will see in some of our examples. So we want to be very clear that the patient-driven payment model, or PDPM, did not change the requirements or definitions for medically necessary skilled therapy evaluations or interventions. So in other words, there were no changes to coverage requirements that relate to therapy services. There were, however, changes to payment and reimbursement structures. So patients who required skilled therapy on September 29th should still have had access to that skilled medically necessary therapy on October 1st, provided by an OT or a PT or SLP. Again, coverage did not change. We saw many different responses, and 2 different response examples to give you kind of a sense of what might have been some appropriate responses are that we saw that the continuation of treating residents based on their individual clinical needs. We saw that some skilled nursing facilities will utilize group therapy and concurrent therapy when clinically appropriate, and kind of do that in looking at each patient in their individual capacity and their needs. And then on the other hand, we saw some other responses. And these are some very specific examples of limiting skilled treatment to 30 minutes maximum per client, for example, requiring intervention sessions to include several minutes of concurrent therapy in each session. We're also getting reports of some facilities where every client who received, in some cases, may have received 60 minutes the last week of September, then started to receive 30 minutes for the first week in October. So seeing that clear change from September 29th to beginning in October. And then that those changes are not in any way tied to clinical need, which is one of our biggest concerns. So knowing that, what you probably want to know, what is AOTA doing about all of this, and what is CMS saying about all of this? We've been doing a number of different things, starting with some of the direct quotes from CMS, or the Centers for Medicare and Medicaid Services that govern PDPM. We hear them saying in their rulemakings, in the final rule where PDPM was implemented, they state, or was put forward, they state that we expect therapists to determine the frequency, duration, and modality of therapy based on sound clinical reasoning and the individual needs of each patient. This is important to know because there are multiple modes of therapy options, as you know. So the modes of therapy, we know that in most inpatient settings, practitioners can provide therapy one-on-one or individual, also in groups or concurrently. In addition, in skilled nursing facilities, concurrent and group interventions have been capped to a combined maximum of 25% of the total number of minutes provided to each client. That is something that actually AOTA, along with our other therapy colleagues, advocated for very significantly to allow this maximum for assurance that patients in skilled nursing facilities would have access to individual therapy, and in most cases, individual therapy when they needed individual therapy. AOTA has also developed many resources on our Volume to Value webpage through our Volume to Value initiative. And one resource really is targeted supporting the clinical judgment of practitioners in determining whether the mode of therapy for their patient should be individual versus group versus concurrent. And that resource can be found and downloaded on aota.org/value. We really encourage you to take a look at that resource because it goes into great detail that we think will be of assistance to you, especially if you are in a facility where you're being asked to provide only group or a certain number of minutes of group, et cetera. So in addition, what is AOTA doing? Maybe the next question you would ask. As we said, when we first heard about some of the changes that skilled nursing facilities were making, we opened a direct line of communication with the lead staff at CMS, John Kane, who oversees the PDPM program. We agreed to update CMS on a regular basis regarding the stories that we're hearing and the policy changes that we're hearing about in response to PDPM from the SNF community. We are in the process of updating CMS on a monthly basis and may look at changing that depending on the responsiveness that we are getting from members, which really continues at a very high volume to be even more frequently if needed. We're soliciting and collecting your stories of OT practitioners out there. We need to know what is happening in the industry and how these changes are not only impacting you, but may impact the Medicare beneficiaries that you're serving. We are monitoring available data very closely. The data that we're speaking to, at least initially right now, is data that is reported by the skilled nursing facilities to CMS, and it's called the Payroll-Based Journal data, which is first expected to be reported in the spring of 2020 under the new PDPM model. But reporting has occurred over the course of the last year under the RUG-4 model. We are also developing many resources that you can find at the website listed here, especially targeting clinical judgment to ensure that the judgment that the OT practitioner brings to the SNF is considered as valued and is really looked at when developing each patient's care needs and plan of care. Not on the slide, but we have just entered into conversations with industry groups to look at meeting together to discuss all of these concerns within the coming months so that we can really understand what is happening, what is not happening, and what the understanding is out there within the SNF industry. We also wanted to point out that these are some SNF actions in this slide that we're most concerned about to give you some additional detail. The organization level mandates that don't really focus on evidence-informed clinical judgment of therapy, and that those types of actions can be viewed as fraudulent or are potentially fraudulent. So they really require your consideration and your focus when you're being asked to do something that you believe may not be appropriate clinically and also may not be in line with Medicare rules and requirements. Some of the examples, again, are being told that everyone must participate in a group, or that every treatment must include concurrent therapy, that all minutes should be reduced by 15%, and really determining intensity more so for staff convenience, but again, not with a focus on the patient clinical needs in mind, which I will be saying over and over again. We want the OT practitioners to be able to clearly articulate when a client is appropriate for a group and when a client is not appropriate for a group, and that the decision be made based on clinical appropriateness over anything else. we also recognize that there are sometimes great opportunities for group therapy activities that this new PDPM rule opens up opportunities for, and sometimes there's learning with other patients that can only take place in a group setting. But again, we also want patients to be able to have individual therapy when they need it and when their condition requires it. So this is a resource. We just have a snapshot of it here that you can download directly for your office, your clinical practice, and to look at for the considerations of the various modes of therapy, and encourage you to do so. So again, here are some very specific clinical considerations that we think you should look at when you are determining whether to provide group therapy versus individual. That activity analysis and the intervention and the client's needs. The number of clients in the group. That's going to be very important as you look forward at skilled nursing facility and how many individuals should be in your group. The stages of rehabilitation and the lived experience, individualized client goals, meaningful participation, and the skills of the practitioner to provide group therapy in the setting. So we know the changes from some SNFs that have responded to PDPM that were not necessarily driven more by reimbursement than by the clinical needs of the patients, are very concerning to us. We believe they were choices made to pursue profits beyond concern for therapists and therapy assistant needs, as well as their patients and the clinical judgment of the therapy practitioners at hand. We again want to reiterate that this is not all skilled nursing facilities, but AOTA is advocating in the cases where we hear about inappropriate policies being put forth to protect the profession, our members, and the patients that they serve. So we, again, encourage you to share stories with us. We have a mechanism by which you can share stories directly with Congress that we just initiated last week. There's a template letter on our website through our Legislative Action Center that you can send in letters, and we're continuing to monitor, and we're requesting that CMS and Congress monitor this issue. So CMS has been very clear that they will be monitoring therapy services and looking at utilization at the national, regional, state, and facility levels. And as Jeremy said earlier, this can be done through the minimum data set section O. There are, if there are significant changes in the amount of therapy, it could result in CMS or Department of Health and Human Services notification to the Inspector General for further investigation. Those bodies are watching staffing levels closely, and to be very much noted, they're watching for patient outcomes. One of the primary goals of PDPM is to really look at quality of care, to focus less on the number of minutes of therapy and to look at the overall quality and the outcomes under PDPM. So with that, we want to just direct you to our SNF OT evaluation checklist that Jeremy referred to as well, where quality measures are set forth. And these are some of those examples of quality measures. For example, in the skilled nursing facility value-based purchasing program, the systems are looking very closely at hospital readmissions, spending per beneficiary, discharge to community. They're looking at preventable readmissions 30-day post-discharge, as well as pressure ulcers, and very much they're looking closely at falls. And in the quality reporting program, quality measures are being closely monitored, as well as being reported out so that consumers can determine which skilled nursing facility to send a family member to, or they themselves might need to look at. And some of these look at admission and discharge functional assessment and care plans that address function. These give you a couple of various quality measures that are looked at with regard to areas that occupational therapy can impact, such as mobility and self-care. I wanted to point those out to you so that you know that quality is really at the heart of PDPM in an attempt to drive a refocus of effort within the skilled nursing facility. So practitioners must be able to clearly articulate and document clinical reasoning for all interventions. We believe that high quality, high value OT is connected to meaningful outcomes, and that OT impacts the measures that we just reviewed, that we all have a role in advocating for the critical role occupational therapy plays in SNFs today and will play in the future. Measures competition and value. Really here, what I want to focus on is to again state that quality measures are being closely looked at by CMS, by Congress, that there's a drive to have outcomes and measurement really in quality drive care. So facilities, it seems to us, and it is the intent of PDPM, that facilities that support and develop clinical judgment will have that competitive edge, and as opposed to those facilities that may have responded with knee-jerk reactions in terms of the various actions that are being taken. They'll potentially see their mistakes and may look at rejiggering their business model in order to really meet those outcomes needed. This is going to depend on high-quality OT being the standard of practice and looking at those areas of analysis that Jeremy went over earlier as the focus of the evaluation and developing the plan of care. So AOTA has been working on promoting high-value OT through our Volume to Value project for over 2 years now, and really has developed a number of resources that we urge you to take a look at. In addition, what AOTA is doing is we have republicized and tried to share again a joint statement on compliance reporting that was developed together with AOTA, APTA, ASHA, and NASL several years ago. It was developed initially in response to concerns with regard to productivity and trying in the attempt to develop a pathway for thinking through the issue and reporting. So I would again urge you that if you believe you are being asked to provide services that are either potentially unethical or out of compliance with Medicare requirements, you have the opportunity to report. As the compliance statement walks you through, we suggest that you try internally first to talk with most skilled nursing facilities have a compliance officer that can be spoken to. You can have the conversation about your questions or concerns. There's also the ability then to report directly to OIG and HHS through an online form, as well as this phone number, 1-800-HHS-TIPS, which also on the online form you'll find more information about reporting. And with that, I'm going to turn it over to Jeremy to talk about the why behind some of this.
Excellent. Thanks so much, Sharmila. I want to remind everyone that there is a Q&A box on your screen, and if you have questions that you would like Sharmila or myself to address, as we talk through this, please feel free to go ahead and ask your questions now, and here shortly we will start digging into those. So Sharmila did a great job of talking about what we're seeing, what we're hearing, and what we're looking at related to the implementation of PDPM. So we know that there are a lot of things going on, and we definitely want to be there to support OT practitioners and also to advocate and demonstrate the solid connection between occupational therapy and outcomes that are meaningful for clients. So in this new value-based system, we're starting to see a lot of changes. And like most other professionals who bill for their services, occupational practitioners must be adept and comfortable at answering the question, why? And physicians really started getting hit with this pretty hard several years ago. And so they've gone through a very similar change where, a number of years ago, if a physician said, okay, we're going to go with this treatment plan, then that was pretty much the end of it. And, occupational therapy in a way has been in a similar situation where if we've said, okay, we're going to provide X number of minutes of therapy, health systems and payers have said, okay, that sounds great. Not unlike physicians, we're starting to be asked why a lot more. And we've got to get comfortable with answering that question, even though it's a really uncomfortable question when we very first start looking at it. So some of these questions might show up and look like, why do you need an additional 15 minutes with this client? Administration or a payer or another person may say, why is this person not appropriate for group? Why did you choose this intervention that you're doing right now for this client? And then why are you the best person to see this client? And finally, why is the scope? There's many other questions that may show up, but just because someone is asking us why doesn't mean that we've made the wrong decision, but it does mean that we need to be able to support why we're doing what we're doing. And really, if you take a look at it and you think about what goes into answering why and what we have to be able to do, really, when we answer why, we're starting to demonstrate our skill. We're starting to show our clinical judgment, our clinical reasoning, how we bring evidence-informed decision-making into our practice. And so answering why, though uncomfortable at first, actually really does show the power behind OT. So again, as I started out at the beginning, we've talked about the distinct value of occupational therapy. We've provided the evaluation checklist, which of course you can download at aota.org/value, and it walks through some key areas. And I think these key areas are really important for a couple of reasons. One, because OT looks at these differently. Two, because these really connect to what a person needs to be able to do to successfully participate and engage in activities and occupations that have meaning to them, and also to be able to live the most independent life possible. And so I think it's really important that we start to look at these and we start to form some of our conversations and some of our documentation around some of these things that OT does differently and even better than most anyone else. So we also wanted to take a second to address that the system is changing, and we actually should start to see some changes because of that. So there's some changes that we should expect to see, and there's also plenty of changes we should not expect to see. So what should we expect to see? Well, management starting to ask practitioners to justify the amount of time that they spend with clients using their clinical reasoning. So starting to ask why 40 minutes and not 30 minutes, why 50 minutes and not 30 minutes, or in some cases, why 60 minutes and not 15 minutes? So we should expect to see those questions. We should also expect to see some questions around interventions, such as, does this intervention that's happening right now require the skills of an OT or OTA? Or why would someone who's less expensive not be as effective at this intervention? And again, if we go to those areas that we've talked about on the evaluation checklist, I think that there's plenty of evidence and plenty of reason that OT is the right person to address those issues. But we need to be able to clearly support with our clinical judgment what we're doing and why it's goal-directed. So we put up some scenarios and kind of to think through, okay, some changes are reasonable, some changes are not reasonable. Let's take a look and see how these things might be different. So as an example, asking practitioners to provide interventions in groups when clinically appropriate. Following up with questions about why a group is or is not appropriate for an individual client. So that's a change that we would probably expect to see and a change that would probably be reasonable. However, on the opposite end of that is mandating that groups occur every week with every client, regardless of clinical or functional presentation. So that's a change that's absolutely not reasonable, and a change that's driven by operational concerns and really doesn't think about the clinical presentation or the best practices for the client. So obviously there's a wide range of situations between those two, but I think that starts to show some of the differences between reasonable and unreasonable. Another reasonable change, asking practitioners to justify the amount of time that they need with a client, and asking a practitioner if interventions that are being used are skilled and reasonable for OT. The other side, the unreasonable expectation of that would be reducing all time across all clients based on operational decisions. So for example, just reducing everyone on caseload blindly by 50%, or capping the total time allowed for OT to 30 minutes, no matter who the client is, what their clinical presentation is, or what their functional presentation is. That's certainly something that we would not expect to see. Another reasonable change is asking practitioners to collaborate with non-skilled staff like restorative nursing assistants to promote carryover or implement routine activities and exercises. So that makes sense. If we've gotten an exercise to a point where it's completely routine, it doesn't require skills anymore, it makes sense for OT to collaborate with an RNA or someone similar to be able to demonstrate some carryover and work on those routine activities. However, completely unreasonable is attempting to replace skilled therapy with non-skilled interventions provided by RNAs, CNAs, or other non-skilled interventions. So I hope that this kind of starts some of the conversation between some of the changes we might expect to see and then some of the changes that we absolutely should not see. We also want to talk about this is the first mile in a larger journey. So a lot of this started with the Impact Act and then continued to transition over time. And as a part of this initial Impact Act, MedPAC, or the Medicare Payment Advisory Commission, is recommending a unified post-acute care payment system. And we don't know, there's no regulation or law saying that this actually has to be implemented yet, but there is a requirement that one be kind of designed and proposed for us to look at and see what that might look like. And there's no doubt that lessons learned through PDPM and PDGM will inform this process. So as we go through this process, we need to know what's happening, what's going on. We need to look at what worked well. And we also need to be able to acknowledge what did not work well, because the payment system is not going to be the same payment system for many years in the future, most likely. We're going to see more changes. And in fact, we know that there's organizations that are already looking at and proposing potential changes. So one more time, I'm going to hand it off to Sharmila to talk about tools and resources that we have available for you.
Thank you, Jeremy. So very quickly, we really just wanted to point you to some of the resources that we've been mentioning throughout the presentation and where you can find them. Make sure that I get in here, sorry. Here we go. So choosing wisely, I think hopefully by now many of you have heard about AOTA's participation in the Choosing Wisely campaign. This campaign involves AOTA promoting and discussing essentially 5 areas of practice that we may want to move toward avoiding or not doing frequently that do not clearly lead to evidence-informed outcomes. And so those you can find on our value webpage, as well as a number of different initiatives related to choosing wisely to provide feedback about the programs and services that you're providing, and to also get questions answered within the program. We've mentioned a number of times now the home health evaluation checklist. There's one for home health. There's also one for nursing homes and skilled nursing facilities. There's also Med B outpatient. It includes really looking at the occupational profile and the core areas that should be addressed as part of your analysis of occupational performance, and we strongly suggest and urge that you take a look at that, download it, bring it with you to practice in completing your day-to-day care. Please go to our website. You'll see a number of various resources related to webinars. We had a one-day conference on PDPM back in June that is available for download on demand and listening to. And as Jeremy mentioned, we have a one-day conference for home health practitioners on PDGM on November 19th coming up, still open for registration. The template, the checklist, section GG within the various assessment instruments on self-care and mobility and modalities of therapy interventions and how to choose the best modality, choosing wisely. I will close it up by just saying for both of us that AOTA, there is no substitute for contextually relevant, client-centered, occupation-based, and evidence-informed occupational therapy, and all of those components are very, very critical in a PDPM and PDGM world. We are continuing to advocate for you. Send us your stories. Send us questions. Reimbursement-related questions can go to regulatory at AOTA. Your PDPM stories or quality-focused questions can go to quality@aota.org. And with that, we are going to take a look at the chat box to see what questions you've asked. And maybe I will turn it back over to Jeremy to see if he wants to take the first couple questions.
Sure, absolutely. So one question is, will this affect outpatient pediatric practice or just adults? That's a great question. So the specific examples that we've talked about today, PDPM and PDGM, are both specifically focused at Medicare population, so Medicare post-acute care. However, we're really seeing a vested interest in Medicaid and private payers and third-party payers who all pay for outpatient pediatric practice and what is happening with this Medicare situation. So we're seeing more insurance companies and Medicaid programs actually start to implement quality measures and starting to measure those quality measures and looking at ways that they can pay for better quality as opposed to more quantity of services. So While these specific changes are specific to adults, the general idea of being able to answer the questions why and to drive practice towards outcomes that are important to clients and health systems definitely also applies to pediatric practice.
This is Sharmila. I'll take a next one. Another question is, where can we access reporting information in the future if need be? I'm presuming this questioner is speaking to reporting, compliance reporting related to CMS, OIG. So the compliance reporting document that we put up on that slide is probably the best source currently. If there are other resources or places to report, we will be updating. We constantly are updating our website. That is the aota.org/value website. That's the best place to go. And if you go up on that website and you click on skilled nursing facility, because we do have a value and quality conversation in all the settings, but this issue around PDPM is focused on SNF and of course PDGM on home health. If you looked at your relevant setting, we will have more information there.
Excellent. We had another question. What is concurrent therapy? And I'm actually going to read CMS's definition from skilled nursing so that I get it exactly right. So it's therapy that is provided to two patients by one therapist or therapy assistant doing different activities. So basically it's when one practitioner is kind of splitting their time between two clients who are receiving therapy at the same time, but they're not doing the same thing or working together in the group. Instead, they're getting kind of the divided attention of the practitioner. And then the next question is, similarly, and I'm sorry, and I'll hand it right back over. If you have 2 or 3 patients performing the same activity in a small group, do you charge for group therapy? And the answer is, in Medicare Part A post-acute care, yes, that is exactly the right thing to do. It is important for us to note that in Medicare Part B, group is a little different. It's basically, well, it would count the same though. 2 to 3 patients performing the same activity would also be grouped there. So yes, that is a fantastic example of a group.
Thank you. I will take another one. The questioner is asking, do you have any specific recommendations for those of us in home health, and what do you feel will be the best tools to help us reflect quality? It's a great question because, you know, seeing starting to see just a month in the lessons learned from PDPM, and again, not knowing how home health agencies will respond to PDGM, which again, similarly, coverage for occupational therapy did not change. Really, the approach to payment changed. I guess I would start and maybe turn it over to Jeremy, but I would start with that evaluation checklist for home health and the occupational profile from a clinical standpoint as really being your go-to resource of organizing your thoughts, your documentation, and identifying those areas of practice analysis that you will focus on, and then really then help you reflect what occupational therapy brings to the table and the value within the home health setting. We know that as a population ages, there's falls, and there actually is really in the policy world a heightened attention to some of the clear clinical issues that the elderly are facing as they're aging to older ages. So being able to clearly document, you know, the outcomes you bring is going to be key. I don't know if Jeremy, if you have more to add to that.
No, I think that makes really good sense. I completely agree. And making sure that you're having, you know, those conversations about everything Sharmila just described with your interdisciplinary team. So it's really important that not only are we as OT practitioners addressing high value activities and achieving solid outcomes, but that we're also, you know, advocating for ourselves and also demonstrating how our services are important to the interdisciplinary team who is treating and working with that client.
I can jump on a next one. The question is, you mentioned there is no hard data on the impact of PDPM on OT practitioners yet. However, you have received hundreds of emails with concerning stories. Are you planning on obtaining data through a survey at some point? So that's a really great question. We are talking about our next steps. We actually are continuing to get those stories, collating them, organizing them, and the data into various buckets so that we can really see those trends. We're kind of in the middle of that now. But I do think that we will be considering something like a survey. We also hope to talk to the industry to kind of get a sense of what they are doing, if they are responding in any way, and to be able to voice those concerns. And so it may be after some of those meetings that we really circulate around the potential for a membership survey. Thank you for that question.
Excellent. Another ask, do you have suggestions on what outcomes to track and how? And yes, we do. So if you look at the evaluation checklist for either home health or skilled nursing, if we're talking about those two areas, they both include quality measures that CMS is tracking for each of those areas respectively. So they even have a spot where you can write down your score for each of the quality measures. And so that's a great way to identify some key outcomes that are really important to be tracking. And you can actually get your current performance from your facility. So Medicare provides very fast feedback to facilities on what their scores are for those quality measures. And if for some reason you're not able to access someone in your facility who knows how to get those, you can look at Home Health Compare or Nursing Home Compare to get an idea of how you're performing.
I'll do then one question. When a company decides to cut what they pay, no, I need to do this. I'm losing it. It's the question that I was looking at is we have been aware that CMS is closely monitoring how SNFs are responding to PDPM. And then the question is there a sense of when they plan to act on unethical activity? It's a really good question. So usually when something like this happens and the reports are sent into CMS or then forwarded to the OIG or Office of Inspector General within Health and Human Services, an investigation ensues that unfortunately often involves having to request documents and go through like a fairly significant document review to ensure that the stories or the anecdotes that have been provided and reported can be proven in evidenced in some way. And so as with any sort of investigation or case, it just takes time on their part to gather that data. So those things might be happening or begin to happen, and you may not know about it because they're just in that data review, document review phase. It does often take a fair amount of time to go through that process and then to decide to take action. And so these things often can take some time. I don't have good numbers for you, but I would say anywhere from 6 months to a number of years to kind of get through, depending on each individual scenario. I'll turn that over to Jeremy.
Excellent. I like this question. What beneficial group activities have you done? So that's fun because I don't get to talk clinical interventions as much as I used to. So I think for me, one of the most beneficial groups that I've run in the past is when I have 1 or 2 clients, usually who are pretty new after some type of a major surgery or injury, who have a lot of psychosocial concerns. So they're starting to feel like the mountain to climb for recovery is just too high to bother with, or the pain in participating in activities, is bothersome. Combining those couple of clients with a couple of other clients who are further along in the journey, let's say using a cooking group because we're able to work on some really high level challenges to someone who is about to go home after a major injury, and we're also able to grade that to some pretty low-level challenges for someone who is really, really acute in the situation. So having one start kind of the prep mechanism and one start some of the cooking mechanism in dynamic standing with some additional challenges and working on the cognitive activities too. I've seen that completely change not only the basic skills and the underlying impairments that we're working on, but also the psychosocial element of being able to collaborate and hear stories from someone who has gone through a similar situation and see how much progress they've made in post-acute care. So I think that's one of my favorite. I kind of combined a couple of different groups into one, but that's kind of one of my favorite beneficial uses of groups.
Great. One more question here. The question is, with the changes coming in for PDGM, can you update us on any progress in allowing OTs to open cases in home health? So we have continued to actively work on this issue. Our federal affairs team is really leading that charge with Congress. There has been legislation introduced called the Home Health Flexibility Act in the House, and there are champions both in the House and in the Senate for this bill to kind of move forward. And the other piece is we have actually met with CMS and members of Congress to push the legislation and been discussing that we really need it in part and need to make sure that staffing decisions are being made based on client need and not who can open a case, because that is something where we need to protect those occupational therapists despite the ability to open a case when PDGM becomes implemented on January 1. And so it's something we've been working on very hard and have a great deal of support on.
Excellent. So when asked, will these changes negatively impact rehospitalization? I think that's another interesting one. CMS is working very hard to make sure that it doesn't. Skilled nursing facilities who perform poorly on rehospitalization actually get pay cuts. And so that's kind of the balance that CMS is setting up. We'll see if it's effective or not. I think we'll have to watch and see, and AOTA will be monitoring that pretty closely. But by creating value-based payment where we're looking at outcomes, if someone is rehospitalized, that counts against the skilled nursing facility in a program called the value-based purchasing program. And the value-based purchasing program takes all of the skilled nursing facilities and uses risk adjustment, but the facilities who perform the worst on rehospitalization measures, CMS actually starts paying them less. And they take all of that money that they're saving by paying those organizations less, and they redistribute it and actually pay the facilities who are doing the best on rehospitalization more. And so it makes skilled nursing facilities compete against each other specifically on rehospitalization as an effort to prevent some of these changes from having that negative impact. And
Sorry,
then
just trying
I will
to make
take
sure. Go ahead.
Sorry. I'll take the last question, I think, and then we'll probably be wrapped up. Has there been any discussion of SNFs being more selective of which patients they will accept now that things are tied to outcomes? So that's another important factor that CMS has kind of put some changes, I guess, mitigated for. So probably one more after this question. I'm told we have a little time. So it's a balancing act, right? Because the best outcomes can impact payment, but clients who needed the most care, so clients who have the most going on with them medically, actually pay the most. And so you have a balance between being paid for client characteristics, so people who are very dependent and have a lot of comorbidities going on actually have a higher payment than someone who is doing really, really well. And then you also have the other side where better outcomes can lead to higher payments. And so CMS, I think they're trying to balance between those two to avoid the possibility of what they call cherry picking, where facilities go out and kind of choose clients based on the likelihood of a high reimbursement mechanism. So we'll see how it works out, but I think there are some factors in place to help prevent that from happening.
And I can try to hit one more. How do we better prepare students for this change in dynamics, and how should they handle potential ethical concerns when on field work? I love that question. I mean, it's a very tough question because it is happening right now. It's sort of the living environment that we're living in, with changes to reimbursement, unfortunately impacting practice decisions. I found that case scenarios, like some of what Jeremy walked through and I walked through with the why and what is a reasonable change or practice versus what one might consider unreasonable. We would happy to share these slides with anyone who wants to present this to their class or their students, or to invite one of us from the AOTA team to do so, because I think that really starts to guide the lines, which are sometimes very gray, we know, from the questions that we get, to try to help them understand where those lines are divided. Jeremy, I don't know if you have anything you want to add to that as we hit 4 o'clock.
No, I think that's a great start. Getting students comfortable with clinical reasoning is I think a really important factor. So thank you guys, everybody for your time, and feel free to reach out to the email addresses if you have additional questions.
Thank you.